Welcome to This Week in Cardiology. This week we're covering 9 notable papers spanning major advances in cardio-renal protection, new strategies for secondary prevention in atherosclerotic disease, and fresh insights into the lifelong management of structural and chronic heart conditions. Let's dive in. We begin with a major story in cardio-renal medicine, covered by 2 complementary papers on the non-steroidal mineralocorticoid receptor antagonist, finerenone. First, in The Lancet, the Infinity pooled analysis combined individual patient data from 3 major trials, Fidelio-DKD, Figaro-DKD, and FINE-CKD, totaling over 14,500 participants. The analysis confirms that finerenone provides robust protection across a very broad spectrum of chronic kidney disease. Compared to placebo, finerenone reduced the composite kidney outcome of kidney failure or a sustained estimated GFR decline of 57% or more by 24%. It also cut the risk of the main cardiovascular outcome, a composite of heart failure hospitalization or cardiovascular death, by 20%. Notably, these benefits were consistent regardless of the patient's glycemic status, the underlying cause of their kidney disease, or their baseline kidney function and albuminuria. The second paper provides the crucial data for one of the trials in that pooled analysis, the FINE-CKD trial, which specifically enrolled over 1,500 patients with chronic kidney disease without diabetes. This trial showed that finerenone significantly slowed the rate of estimated GFR decline compared to placebo over 32 months. Hierarchical testing also showed a lower risk of a composite kidney or cardiovascular outcome with finerenone. As expected, hyperkalemia was more common with finerenone, but discontinuation due to this was infrequent. Together, these papers solidify the role of finerenone as a foundational therapy for a wide range of patients with chronic kidney disease, extending its proven benefits beyond the diabetic population. Next, we turn to 2 papers from the European Heart Journal that refine our approach to secondary prevention in patients with established atherosclerotic cardiovascular disease. First, a meta-analysis addressed a persistent clinical question: after PCI, how long do we really need dual antiplatelet therapy? The analysis, which included 11 randomized trials and over 37,000 patients, found that discontinuing aspirin at either 1 month or 3 months and continuing with P2Y12 inhibitor monotherapy yielded a similar risk of major adverse cardiovascular events compared to continuing DAPT for 12 months. However, this strategy of early aspirin cessation significantly reduced both major and minor bleeding. The authors noted a potential trade-off. Stopping aspirin within the first month may offer the greatest bleeding benefit, but a sensitivity analysis in acute coronary syndrome patients suggested this very early discontinuation might come at the cost of an increased risk of stent thrombosis. This highlights the need to balance ischemic and bleeding risks on an individual basis. While we optimize medications, another study focused on optimizing risk communication. The new SMART-ASH EACH2 model aims to predict lifetime cardiovascular risk and the benefits of treatment in patients with established ASCVD. Developed in a large Dutch cohort and externally validated in over 2 million patients from 54 countries, the model provides estimates for both short-term and lifetime risk of recurrent events. Its key feature is the ability to quantify the potential gain in cardiovascular disease-free life expectancy from intensifying preventive therapies. For example, for a hypothetical 50-year-old patient, lowering systolic blood pressure by 15 mm of mercury and LDL by 1.0 millimoles per liter could add over 4 years of disease-free life in a very high-risk region. This tool is designed to facilitate the shared decision-making recommended by current guidelines. Our third theme covers new perspectives on cardiac structure, genetics, and inflammation. A fascinating analysis from the DECLARE-TIMI 58 trial explored the effect of the SGLT2 inhibitor dapagliflozin in patients carrying genetic variants for cardiomyopathy. Among over 12,000 participants with type 2 diabetes, 121 were identified as carriers of pathogenic or likely pathogenic variants. In these high-risk individuals, dapagliflozin's effect on preventing hospitalization for heart failure was profound. The hazard ratio was 0.18 in carriers compared to 0.70 in non-carriers. This translated to a stunning 13% absolute risk reduction in the carrier group versus just 1% in non-carriers. Since most of these carriers had no prior heart failure, this suggests SGLT2 inhibitors could be a powerful tool for primary prevention in genetically predisposed individuals. Shifting to valvular disease, A large systematic review and meta-analysis in the European Journal of Heart Failure quantified the prognostic importance of a frequently overlooked condition, tricuspid regurgitation. Analyzing 106 studies with nearly 1 million patients, the researchers found that untreated moderate to severe TR was not only common, with an overall prevalence of 13.5%, but also dangerous. It was associated with a roughly doubled risk of all-cause mortality, cardiovascular mortality, and heart failure hospitalization compared to mild or no TR. This association held true across various patient subgroups, underscoring the need for timely diagnosis and appropriate management. Finally, a basic science paper in Circulation offers a potential new mechanism for the coronary arteritis seen in Kawasaki disease. Using a novel mouse model, researchers found that hyperactivation of the hypoxia-inducible factor II, or HIF2, in cardiac vascular progenitors led to coronary artery dilation, inflammation, remodeling, and thrombosis. A striking recapitulation of the cardiac involvement in severe Kawasaki disease. This work establishes HIF2 as a central driver of these pathological processes and provides a valuable new platform for exploring future therapies. Our final theme examines two different models of chronic care. First, a review in JAMA provides a sobering overview of the long-term journey for survivors of cyanotic congenital heart disease. While surgical advances mean that survival to adulthood is now common for conditions like tetralogy of Fallot, transposition of the great arteries, and single ventricle physiology, the victory is often incomplete. These patients face a lifetime of significant risks, including valve dysfunction, arrhythmias, progressive heart failure, and premature death. For instance, up to 15% of adults who underwent an older atrial switch operation for TGA may experience sudden cardiac death at a mean age of 30 to 35. The review strongly reinforces that optimal outcomes depend on lifelong, multidisciplinary care from specialized teams. In contrast, a randomized trial in JAMA Internal Medicine tested a scalable care model for a much more common condition, type 2 diabetes, in an underserved population. The study evaluated a structured telehealth intervention using community health workers, or CHWs, for low-income Hispanic adults in Texas. The intervention, which included group education, individual coaching, and a novel feedback loop connecting the participant CHW and clinician, led to significant improvements over usual care. At 12 months, the intervention group saw a 1.0 percentage point net reduction in hemoglobin A1c, along with significant improvements in cholesterol levels and adherence to ADA guidelines for foot exams and urine microalbumin screening. This demonstrates how structured, CHW-led programs can effectively reduce care fragmentation and improve outcomes in high-risk community settings. If you only have time for one paper this week, make it the genetic analysis from the declared TIMI 58 trial in Nature Medicine. The finding that dapagliflozin's benefit in preventing heart failure is magnified more than tenfold in carriers of cardiomyopathy variants suggests a powerful new direction for genetically targeted preventive cardiology. Here are the key takeaways from this week in cardiology. First, finerenone is now an established therapy for reducing the progression of chronic kidney disease and improving cardiovascular outcomes across a wide spectrum of patients, importantly including those without diabetes. Second, in patients post-PCI discontinuing aspirin after 1 to 3 months while continuing a P2Y12 inhibitor monotherapy effectively reduces bleeding without a clear increase in ischemic events, though caution is warranted, with very early discontinuation in high-risk ACS patients. Third, do not dismiss moderate to severe tricuspid regurgitation. A new meta-analysis confirms it is a common finding associated with a doubled risk of mortality and heart failure hospitalization, reinforcing the need for active surveillance and management. Fourth, genetics may soon guide primary prevention. In patients with type 2 diabetes, carrying a pathogenic cardiomyopathy variant identifies a group that derives exceptional benefit from SGLT2 inhibitors for preventing heart failure. And finally, from complex congenital heart disease to community-based diabetes care, structured, team-based approaches are critical for improving long-term outcomes in chronic cardiovascular conditions. That's your roundup for this week in cardiology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary for clinical decisions. Always consult primary sources and current guidelines. See you next week. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.